All right, good evening, everyone, and welcome to tonight's session. We'll be talking about termination of pregnancy, but we'll look into the options that you have in the early trimester. I want to call it early trimester because there's that overlap that is there all the time, which understandably so, because for you to determine the gestational age, you would have used the first day of last menstrual period, assuming that it was normal, which is not an automated thing to find an explanation from a patient of a normal one. If not, you would have used an ultrasound, again, which is operator dependent. Even on that one, as when you see, when it calculates the gestational age, it will tell you plus minus, which means chances are you are wrong with an extra of this much or a less of this much. So that's why I want to just call it early trimester because you'll see 1 week or so overlap on that. So just to declare that I'm a joint employee of Charlotte Mateke Johannesburg Academic Hospital and Vets. Like he said, I'm the academic head of gynae oncology, and the talk is not a sponsored talk. We time and again volunteer our time, which is good for society, good for the medical environment and medical community, and the healthcare industry in general. As a form of an introduction, it's important for us to know that this termination of pregnancy was not something that was thumb-sucked. It was an act that was enacted somewhere in December 1996. It's called Act 92 of 1996, the CTOP Act, Choice of Termination of Pregnancy Act 92 of 1996. So even though it was enacted in December, the practice of that act or implementation started somewhere in February 1997. Some of the reasons why this was brought into space was because termination of pregnancy related death, in fact, termination of pregnancy has been happening. I know there are some people who say that government introduced this evil thing that was being done. Termination of pregnancy was happening. Don't be fooled. It has been happening in villages. People who come from the rural Limpopo and Pumalanga will tell you they know of stories of people who lost their lives. It's because termination of pregnancy, death were like a lot. After the introduction of this act, there was a decrease by over 90%. But still, we still have unsafe TOPs that are done in 23% of women. They still cause death and the burden of disease. This is why the department then decided in between 2004 and 2008 to amend the act so that they can broaden up, so that they increase the catchment, so that they can increase the 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 the, the number of service points that women can go to get this termination of pregnancy. And this included the nurses being trained so that they can continue to give this service that is so much needed. And some of the barriers, what make women not to do termination or still continue to do unsafe termination of pregnancy, included that you might find that there's a provider bias depending on where you are, and you might have opposition. I remember in one of the facilities, I won't mention which one, in Bara or Joburg or Raima, they used to be a lady who will come and pray for the patients there who are coming for the TOP. That on its own, you are barring the people who have made a decision to come and get TOP, because in that prayer, you want to insist that they must feel religiously guilty. And they are also being stigmatized, and hence they stay away. The other important part is the lack of infrastructure, which includes the analgesia and the equipment. If you end up improvising, there'll be trauma, and patients go out there and tell other patients or other potential clients that do not go there. This thing is so traumatic, it's so painful, they don't even give you anything to numb you. Or you have people who are not trained who are providing this, and they end up causing a danger or complications to patients, or lack of knowledge from both healthcare providers and the patients in general. But of most important is the unmet needs for these patients regarding contraception. For us to continue, before we go on and talk about this termination, There are basics that we need to know, and some of them include the definition. What is termed unsafe termination of pregnancy is any procedure that is done to terminate an unintended pregnancy, which is carried out either by a person lacking the necessary skill or in an environment that does not conform to minimum medical standards, or both the lack of skill or the environment. This is the commonest unsafe termination of pregnancy that happens, is a both side. It's very common that you get a patient when you are working in casualty or GOPD casualty who comes in bleeding, and they'll tell you that they went into a certain garage and they were given tablets by a certain man. He says, just go and put them in, then you'll bleed. So that's by definition an unsafe termination of pregnancy for both, which is a risk to the morbidity and mortality on these patients. They are likely to lose their reproductive function or their life. By definition, when we say you are a trained provider, you must be a registered practitioner, whether you are a nurse, a doctor, or a midwife, and counselor who have completed a prescribed termination of pregnancy services training. I know there's an overlap for people who are in academia, because when you're done specializing like Billy, do you now say, I'm not, because I'm not trained for termination, am I not a trained provider? There's no way that somebody will go and attend a course, even if it's for 2 weeks, but you have been doing TOP for the period of 4 years that you are there, that you are not trained. You are trained, you just need to prove to people that you are a specialist. By definition, a first trimester means 12 weeks and less, or 12 weeks, 0 days and less, which is counted from the first day of the last menstrual period. So, but this might overlap, like I told you, to include 12 weeks, 5 days, or 12 weeks, 6 days, depending on what we are using. Again, on the definition, you need to take into cognizance the age of consent in South Africa for heterosexual and homosexual sexual acts is 16 years. However, when the patients are coming for TOP services, there is no age restriction. So there's no need to ask a patient how, or a client how old they are. As long as they are matured enough to have indulged in that sexual activity, it is assumed that they are able to choose whether they want to do this or not. So, of course, there'll be some exceptions that I'm going to talk about just now. On its own, termination of pregnancy by definition is as per description in the Act, which I assume that everybody who's here is aware of the Act. So, like I said, there have been 3 acts since then. The Landmark Act number 92 of 1996, which was actually a bare minimum, a skeleton, which was not well descriptive of who comes in where. And then there was still a lot of barrier because of poor understanding, where providers were considered to be doctors only, and nurses were just there to look after the patient after the care. And then further on, there were no description on who gives the pill, where to put the pill. There was no description on how else can you put the pill and stuff. So which led to the amendment of Act 38 of 2004, which was further amended to Act number 1 of 2008, which is the one that we will be quoting today on whatever that we're saying, because it's an inclusive one, which broaden the whole scope of doing this. So according to the Act, these are the 3 columns that you need to know, that up to 12 weeks, 6 days, which is considered the first trimester in the Act. So this termination of pregnancy can be done by any registered and trained medical practitioner, a registered and trained nurse, a registered and trained midwife, and it has to be done upon request from the woman. No other reasons are required. Of course, if you are in a place where you do termination of pregnancy for financing, for commercial purposes, of course, you'll ask if they have money or not. But the rest of the services, the places that offers them, like in public health sector, no question should be asked. Between 13 and 20 weeks, yes, there are other prerequisites that they have to be met. And this TOP can only be done by a registered and trained medical practitioner. If you look there, they've removed trained nurse and trained midwife. So these are the TOPs that will be done either in a facility or hospital where there's a trained medical practitioner who will be responsible for administration of all the medication, the procedure itself, and the post-abortion care that is supposed to be given then. They'll be in the lead of that care, not necessarily them giving it. But there are conditions that should be met as well. So you should have been convinced that the continued pregnancy will pose a risk of injury to the woman's physical or mental health, and there must be a substantial risk that the fetus will rather suffer from physical or mental abnormality, or that the pregnancy resulted from a rape or an incest, or the continued pregnancy would significantly affect the social, economic circumstances of that woman. So if you look into those conditions, it's still a very broad and open that you cannot argue with somebody who says, yes, I came here driving that Lexus, but I'm telling you, I don't want this pregnancy because financially I cannot afford anymore. You cannot argue with that person because it's them who cannot afford. As long as you are going to do everything within the prescribed limit according to the act, then you are safe and to go ahead and do it. Whereas after 20 weeks and 6 days, because after 21 weeks, it is assumed that you won't be able to do it. So after 20 weeks, 6 days, again, there will be two practitioners who will have assessed the patient and they look into the patient's or the woman's danger, the malformation of the fetus, and stuff like that. So, of course, this is what basically the act offers, but we know that for medical reasons, people can go up to 23 weeks because the patient's life will be in danger. And of course, these are common in academia. All the registrars that are on the platform will tell you that they've done a lot of termination for severe preeclampsia with organ dysfunction. So where can we perform this termination of pregnancy? So the places that you perform this termination of pregnancy must be meet a certain criteria. It must be a place wherein you have good access to medical and nursing staff, and then it gives access to the theater and stuff and stuff. So I just put in this table because the rest of the things we are going to list as we go on and go on. But this is an introduction to, so that before you know that you are going to do this first trimester pregnancy termination, you know that you met that. Here they are. So it must be a place that gives access to medical and nursing staff. So the keyword being giving access. It doesn't say there must be nurses and medical staff there. It must be a place where it gives access to an operating theater. I'm saying this because if you have your own practice that has people that are trained, but when we say you have access, you need to prove to them that you've got a contact with nurses in private that come as and when you need them. You've got a contact and agreement with a private hospital nearby and an agreement with a public hospital nearby that should there be an issue, you'll have access to theater. Has appropriate surgical equipment, which you are going to need, you may need, not only for the TOP, but also for management of the complications of those TOP. And that place must be able to supply drugs. This is not about C and D, is not about access. They must be there. D, you must have drugs that are IV and IM that you're going to need. One of them is syntocinon that you are going to need for contraction of the uterus. Of course, adrenaline in case the woman goes into shock. So, of course, the vacolitas that you are going to need so that when she goes into shock, you're able to resuscitate whilst you are arranging to transfer her. You must have the resuscitation equipment access to, or access to the emergency. So there must be an emergency trolley that is there, well equipped. But this facility must give access to transport. So whether you hire that transport or it belongs, if it belongs to the facility, is the perfect way. If it doesn't, there must be an arrangement that is written that this is what our facility has. So it must have facilities and equipment for clinical observation when the patient is coming before, so that you don't do TOP and risk a patient dying who have hypotension, who have anemia. So it has appropriate infection control measures, which includes cleaning of the equipment, disinfection of the equipment, the equipment that you're going to use for draping and trying to make sterilization, or the equipment that you have cleaned, you need to be able to autoclave them. So if you have that small portable mobile autoclave, your facility can be a good place. It gives access to safe waste disposal, because remember, you are dealing with human tissue here, and the Human Tissue Act dictates certain ways that you must dispose human tissues. There must be a means of communication, telephonic or otherwise, and that place must have been approved by the member of the Executive Council or the MEC and gazetted, or anybody representing office of the MEC. But of note is that, so that can be withdrawn anytime, and the minister has more powers to even override what the MEC had said. So the reason I was saying that is because I know there's a lot of nurses who have attended, a lot of doctors who have attended, because I want to encourage you to make sure that your facility is properly registered to do TOP, so that you don't find yourself in trouble with the council. These are some of the things that you need. At the end, I'll show you the form that you need to apply if you're in Gauteng, but if you are in other places, the form is similar, but you don't go to Gauteng Health. Of course, you go to Mpumalanga Health if you're in Mpumalanga or Limpopo Health. So the reason I'm emphasizing on this is because I know that a lot of us are breaking the rules. So what happened if you are a hospital or a facility that offers 24-hour maternity service? The fact that you offer 24-hour maternity service, so you can do TOP up to 12 weeks without even obtaining approval from the member of the Executive Council, but you inform them. So you don't apply. Hence, you see that people do TOPs in private hospitals and in public hospitals without even application. But they provide these statistics to the MEC or office of the MEC, because they need to have the statistics. Like I said, the minister has the powers to override anything. This is a procedure that is done. A woman still needs to give a consent. So the consent that they are going to give, they'll be giving a consent requesting a TOP, and the medical practitioner or registered midwife shall complete that standard consent form. So this consent form should include the TOP itself and other possible procedures which may be done as and when it's necessary. May I please just mute a little bit and try and stop this guy who's making noise? All right. So that consent should include the consent to TOP. There is a standard consent that if you go to the DOH hub, you'll find the consent, the standard consent. But when you give that consent, you must also include the management of yeah, this animal is bothering me. Okay, hold on. Okay. So the consent include consent to TOP itself by any means, or the means that you have planned with the patient, and the consent to manage possible complications. So that it should include that. Whereas if you are looking at the consent for mentally ill and unconscious patients, this is that special group that I talked about. Please do not think that they don't have rights to termination of pregnancy. They do, but who will sign that consent? It's either the natural guardian, the spouse, the legal guardian, or the curator. That list is in that order. So the first person you look for is the natural guardian, then the spouse, then the legal guardian, or the curator personnel, and the two medical practitioners, or a medical practitioner and a midwife must sign that consent. The consent had two components that needs both the medical practitioner and the nurse who's there, because you do not want to be coercing the patient to do the TOP. So if the natural guardian, spouse, legal guardian, or curator referred to refuse, please be informed that the medical practitioner or the medical practitioner, two medical practitioners or one practitioner and a midwife or a nurse can sign that consent and override that. Should there be a need for that TOP, because some of the indications are medical related termination. So of course, you need to offer this patient counseling. So what form of counseling are you supposed to be giving them? So you're supposed to be giving them, there we go. Yeah, those things happened again. So the counseling that you are supposed to give them includes counseling for the procedure that is going to be taking place, and you give them sufficient information about the procedure and other means and ways of managing this, which means that you would have asked the patient that there are alternatives to doing TOP, which include the following, including adoption of the, giving the baby for adoption and stuff. But remember not to coerce the patient. You are just giving them so that they get an informed choice on what they are doing. So, but the counseling must also be able to advise them on alternative termination services, medical versus surgical. Do we need this? Do we do under GA or under conscious sedation and stuff like those? So that those things must be some of the things. You also tell them about the risks that are associated with termination and the need for contraception, because you do not want to put the patient at risk of complications because there will be habitual use of, termination of pregnancy services in your facility. But on top of that, you add that whatever that is happening, the counseling and the procedure itself and the choice of the procedure itself, these are personal things and they are private. Unless they want to share with anyone, you do not have to share with anyone, including their parents. So for a person who's doing this, you must have been trained uh, to do this course. You must have done a course to do this procedure. And the people who can do the procedure, like I said, a registered medical practitioner according to the Act and registered with the HPCSA, a registered nurse, registered with the Nursing Council, registered midwife, registered with the Nursing Council as well. So these people should be able to, they will be trained on how to give counseling, how to communicate when it relates to TOP. They'll be given clinical competence skills, how to give analgesia or anesthesia, the knowledge on contraception, post-abortion care, the management of reproductive system infections, which might occur because of the TOP itself, or because, again, the fact that the patient is pregnant means there was unprotected sex, which is an increased risk for STIs. So if initially I had indicated that the doctors who are in training would have done this, but for the midwife, they should have completed the training course. So now we go to the main reason why we are here today. So whatever that we talked about was a preamble, but preamble so much related to what we are about to talk about, which is the medical termination of pregnancy. So medical termination of pregnancy, which will be the termination that is an alternative to what we know as suction curettage or an inivac that we do. It's purely the use of purely medicine or drugs, unless if it fails, which we are going to talk about not so long. So, but the drugs that you use for that TOP is these drugs that are put here. The first one on my left, I'm not sure where it is on you. On my left, it's a mifeprostone. It's 200 milligram a tablet. The other one on the right is a misoprostol, also known as Cytotec, which is a 200 micrograms or so. So the one that is there on the box is 200 microgram. Please take note of milligram versus microgram, because when you give a dose and somebody says give 800 microgram and you give mifeprostone 800 milligrams, then so there's going to be a problem. So, but what are these drugs? So I see Dimakato has raised their hand. Is it something urgent, or can't we deal with it towards the end, Dimakato?
Yeah, let's ignore. We will deal with hands at the end. Thanks.
Thank you. So what is mifeprostone? It's important to know the drugs that you are using. In simple terms, mifeprostone, it counteracts the placenta that is there. It's an anti-progesterone drug. It's a synthetic anti-progesterone drug which competes, which is a competitive inhibitor of progesterone. We know that pregnancy is maintained because there's a progesterone that is produced by the placenta and by the ovaries. So if you have a drug that can oppose progesterone, it means that that pregnancy will not be maintained. So if this drug can block the action of progesterone, it alters what's happening on the endometrium, which is where this progesterone is seated or is most active, and it induces the bleeding. With that bleeding, it will be that termination that is happening. So it results in an irreversible inhibition of the transcriptional activity of progesterone. So after it's given, there's no reverse. It's given, is done, is done. Whereas a misoprostol it's an analog. It's a synthetic prostaglandin E1, which is an analog. It's a look-alike. What it does is it binds to the myometrial cells and causes strong contractions, and ultimately resulting in expulsion of the tissue. And it's used off-label. That must be known very well. The patients who are buying misoprostol from some garages, they are paying 1,800 for 6 tablets. They are doing so for a tablet that costs less than 10 rands. So because it's used of record, misoprostol is a drug that is registered for ulcers. So it's just that they had observed that all the patients who were pregnant and had peptic ulcers, when given misoprostol, they end up losing their pregnancy. And people use it off code. That's why if you look into the box, the manufacturer will never write that is for TOP or induction of labor. We are using it off code. So if you look at these drugs, you can see that they'll sort of augment each other. Mifeprostone will make the placenta to detach. Misoprostol will open the cervix and make that placenta that is detaching to be expelled because of the contraction. So they augment each other. So how, and when do you give? So if you have a pregnancy that is less than 12 weeks, I must say that medical termination of pregnancy is most effective. More than 95% successful rate will be when the pregnancy is 9 weeks and less. When it becomes between 9 and 12, so the success rate ranges from 88 to 92, somewhere there. So just you know. So with a combine, if it's less than 12 weeks or whether it would be 9 weeks, you give them 200 milligrams of a single dose of mifeprostone. They swallow, and then they get 800 micrograms of misoprostol. It can be sublingual, can be vaginal or buccal. So I know that there's GP friends of mine who really don't like to do PV. If you have done a sauna, you have checked an LMP, and then it's an intrauterine and it fits the criteria. You do not have to push it in the vagina, but patients can also do it themselves. You can tell them that they can do. That's one of the things that we're going to talk about, which patients you do in the facility, which patients you do out. So it's still coming. So they say that the timing has to be 1 to 2 days after mifeprostone. So I see the department here because this is from the Department of Health, was trying to err on the better side of caution. Most of us give this 6 hours after, not 1 to 2 days, which is 24 to 48 hours. 6 hours after, because they were afraid that even though mifeprostone, the action, as I told you, it also induces some contractility. So if you are going to give it immediately with misoprostol, you might have an exaggerated contraction of the uterus, which is a risk of a rupture. So then this is a single dose, repeat dose can be considered. So until you achieve what you are achieving. So they say there's no limit about that. However, you must be careful, because if it's not working, chances are there must be something wrong, which we're going to talk about at the end. So when can you use misoprostol only? So in patients who are less than 12 weeks, so if you are using misoprostol only, you can use it as above, but always remember that these drugs works better together. So you can give 800 microgram sublingually. You can give it, repeat every 6 hours. So the patient will come and take it at 12, at 1800 hours, and then at midnight. But you need to tell the patient, because when they feel the pains or the contractions that are there associated with these drugs, they must not stop, because they will now change themselves to an incomplete miscarriage, which might end up needing to be evacuated or aspirated, which is what we're trying to avoid by saying we are going to give medical termination of pregnancy. So you give them every 6 to 8 hours, and then until that effect happens. Of course, you'll bear in mind the complications or side effects, which we are going to talk about just now. So if you look at into medical TOP, it's a multi-step process, which involves these two medications that we talked about, which can be given as multiple dose, which is better than when you're using one. It's more safer and effective, and avoids doing other surgical procedures if you are using both of them, and achieves a success rate of 95 and above. And it's most effective at 9 weeks and less, and up to 13 weeks and 0 days, it becomes less and less effective. Misoprostol only has about 85% success rate. So hence we are saying that you must give it as a combination. Mifepristone used to be one of those drugs that you can only get by shipment. Now it's an essential drug, so it's available even in the public sector. It's now available. So even in private, if you want to order it, you know that you'll find it in with ease, and the cost is not as much as it was then, because the cost of one tablet was used to be more expensive than the entire cost of the misoprostol that we have. So the combined regimens results in the faster TOP and fewer side effects than misoprostol. Fewer side effects because you are not going to repeat and repeat that misoprostol. So there is an opportunity that you can use to say the patient can put this misoprostol at home. So please do so for patients up to 10 weeks. So you give them mifepristone, and then you tell them that the rest they can put at home, the misoprostol. You tell them how to put, whether they're going to give it PV, intrabuccal, or oral. At home, it gives them privacy, because nobody has to time and again do PV and put fingers there. It's convenient. They can do it at their own time. It's acceptable to patients. It's safe, and it's also effective. But the facility based, there's ones that are more than 10 weeks. If you have more than 10 weeks, try by all means to avoid giving these patients to do at home, because their chances of bleeding severely, it's more and more compared to those ones that are 10 weeks and less. So you do not want to have a situation where you now see the mother walking in and say she bled until she died. So rather stick to the rule and say we're going to do it here in the facility. Rather have your TOP services running in the morning. If you are afraid that you might need the whole 12 hours, run them in the morning. When they're done, then they can go home. So if you are in a private sector, you can agree with the patients. They come, they get, they book, you counsel them. The next morning they come, they go straight to get their drugs. They wait there until everything is done. That's if they're 10 weeks and more, because you want to be safe. So, and you should be able to give them that access to emergency care if they are more than 10 weeks. So, but please bear in mind that an ectopic pregnancy will not be expelled by either this or a combination of misoprostol and mifepristone. And unfortunately, ectopic pregnancy is one of the commonest reasons why termination of pregnancy fails. So please bear in mind that an absence of bleeding is a possible indication that this pregnancy might be ectopic, but it might also mean that it's an intrauterine but not terminating. If it's not terminating, why? Some of the things is the technique that you are using. Are the tablets into the vagina? Are they into the posterior fornix? Because if they're just sitting into the vagina, absorption is less as opposed to when they're in the posterior fornix. Is there not a lot of heavy mucus in the vagina, which might be hampering that absorption? If it's taken oral or buccal, did you tell the patient that whatever that melts, she can swallow? Or is everything just accumulating there? Although we know that sublingual has a very good absorption. Or is the patient not taking some of these non-steroidal anti-inflammatory drugs that are strong, like mefenamic acid, the phenamine, which could be counter, although they might not completely counter, but which might be counter and delay the effect that you are expecting there. So you need to evaluate the individuals for ectopic pregnancy if they report signs and symptoms of an ongoing pregnancy after the TOP. But please remember, even if they're ectopic and you give misoprostol, there might be some bleeding. Don't say, but she was bleeding in the beginning, it just stops. So the decidua might react and then there will be some bleeding, but it will stop and then the termination will not proceed. So do not let the patient die of an ectopic because we are still thinking I can give it a chance because I heard Mbodi says there's no limit to how much. If your methods are not working, you need to reevaluate to confirm one, is this the correct gestation? You might be dealing with a bigger pregnancy here. Two, am I using the correct drugs as the guidelines? Three, are there no other things that are preventing a good absorption? Four, is this an intrauterine pregnancy or not? So after 10 weeks and 0 days, you need to do this in a facility that is registered. So these patients should remain in the facility until the expulsion of pregnancy is complete. If they are 12 weeks plus 1 day, remember that we talked about that 12 weeks. So you can still give them a combination of both mifeprostol 200 oral as a single dose, and then you give them 400 microgram of cytotec or misoprostol sublingual baca. Again, they say it must follow 1 to 2 days. We always say from 6 hours, 6 to 8 hours after mifeprostol you can give. And then they say here you can give it every 3 hours. Those of you who want to be in the caution side of things, you can say 3 to 6 hours, then you choose to give the maximum component. The reason the dose is reduced here, the bigger the pregnancy, the more the risk of a rupture, because now it's carrying such a heavier load, a heavier passenger, and the myometrium has to contract with so much strength. If you give it a full dose, there might be a rupture. So a full dose as in that 800 microgram that we're giving in the beginning. So you can never give a misoprostol only for a more than 12 weeks and 1 day, because this is where we are going to finishing our first trimester. Never ever give it alone. It will not work. So you'll end up having an IUFD in there. When you are giving this, please always remember there's a need for pain control on patients that are getting this medical termination of pregnancy. So the pain there is related to both physiological and mechanical dilatation of the cervix and contractions of the uterus, but it also psychological as well. So you can use both pharmacological, which is drugs, and non-pharmacological methods, which means your counseling can be also, an analgesic, and it works well to reduce the pain. The more patients understand why things are happening, the more they'll be comfortable and they sit calmly there and wait for the completion. All individuals must be afforded pain medication before a medical or during a surgical termination of pregnancy. One of the ways that you are going to do, I've put in this here because I know that we said we are doing medical only. Unfortunately, if your medical termination fails, you end up needing to do the surgical component to complete it. So you are going to give a paracervical block, and the technique that you are going to use, you are going to put a valcellum or teneculum at 12 o'clock. So before you put a teneculum or valcellum, superficially an injection there with a Marcaine or lignocaine or whatever that you are using, uh, so that when you bite with that teneculum or valcellum, the patient do not feel the pain. And then after you have done that biting, you then do a retraction, and then you inject at 2 o'clock, 4 o'clock, 8 o'clock, and 10 o'clock, so that you can numb the entire cervix. So with numbing of the cervix, it means that if you have to do surgical management, you'll be able to extract whatever that is there or that is left, if there's just clots and stuff, and small stuff, without the patient kicking and screaming, because you do not want the patient to have such a bad traumatic experience. So this is just going on how to dilute the lignocaine and how much do you give, which percentage and stuff. So we'll not go deeper into that. If you need it, if you go to the DOH hub, you'll find this document. It's self-explanatory. Or if you go to IPAS, you will find that the document is there. Here are some of the pain management that you are going to give. You can give to your non-steroidal anti-inflammatory drugs like an ibuprofen. And then if you are going to do surgical TOP, so you might increase the strength. If it's medical, there's no need for local anesthetic, whereas it's surgical, you need a local anesthetic. You might have to give patient an anti-anxiety drugs or sedative like a diazepam. Rather, you prefer the smallest dose of 5 milligrams because if these patients are in the facility, you want them to be awake and not be drowsy so that they can go home. Whereas when you're doing surgical, you can give even fentanyl, midazolam, and propofol and diazepam. Remember that this will be done in a facility. So hence, you've got that luxury of even taking bigger guns because if the patient is not fully awake, you can retain her. If there are complications, you'll be able to manage them because you are in a facility that is registered, such as the hospital. So what adjunct medicines do you give for these patients for pain? So if you are doing medical TOP, so of course you are going to give them an add-on. Misoprostol causes a lot of diarrhea. You'll give these patients loperamide because the fact that they are doing TOP, you don't want them to be suffering, running to the toilet as well. Give them loperamide, but it's not all the patients who will have diarrhea that disturbs them, but it's all the patients who will have diarrhea. So they will also have hypothermia or some form of fever. You need to reassure the patients that there will be that. But if you are giving them an ibuprofen, then it will help. So after taking you through to that, then there's an issue about how do I then apply for my facility to do TOP. Whether you are a nurse with a clinician nurse, you are a GP or any other person, because the people who run Maristopes that you know are not even medical doctors, but they did the same thing. They applied to have their facility do TOP and for the training. So when you apply, they are going to need the details of the applicant. In other words, if it's a business, who's the owner of this business? So, and then details of the personnel that are expected to be there providing the services, and what is the extent of the present demand of these TOP services around there, which will be estimated by you, and what is the potential future growth? Do you think you are in Protea and Protea is expanding? There's a new development, and you provide them with a map, including the map that tells them that you had said there must be access to 1, 2, 3, 4. I'm saying access to theater is Krisani Barakwanat because according to the map of Soweto, this is where I am, this is where Bara is, for example. And then your facility must be will be evaluated for designation as a TOP service provider. There will be a person from both the regional and the provincial office who will come to evaluate your facility. So which means that for you to apply, you should have now have either started renting the area, renting the room, um, or converting your praxis, getting all the stock, and then you apply. Then they will come and evaluate. If there's something missing, they'll tell you you need to add 1, 2, 3, 4. So until you're done, then they'll give you a certificate. Then your practice will be authorized. But part of the thing includes the training that is required to do TOP at facilities. And then, like I said, you register with your GOH provincial and regional partners. And then if we talk about training itself, IPAS, the same company that provides with the equipment for suction curettage or for aspiration, also provides skills, uh, as in they train you, they take you in a workshop. I've asked from the Department of Health, they are one of the providers that provide the services. So if anybody is interested, I can give you an email address of a person you can email to and say, I would want to provide that to be provided with that training, or my medical officers, my midwives in the facility will like that to be provided for me. So they also give you the equipment in case you want to do surgical TOP. But even if you are going to do medical only, you might find that when it fails, you end up assuming to do a surgical TOP. So they train the doctors, the registered nurses, and the registered midwives. So my plea to you is that you need to go there, get the skills, get correct drugs, get correct equipment, reduce complications, reduce death, increase affordability and save TOPs. Because right now in the streets, they are getting a lot of, they are paying a lot of money for doing TOP that is not even the correct TOP. So in Gauteng, this is how the application form looks like. This is the front page. The next page just need those details that are there. So the ARFN number, which is the stand where you are, because they need to know and locate it on the map to see where you are. Then, then the personnel that are there, they want to know the listing of those. It does not mean that you need to have all those people. So because the other people, we can say you have access to them. So, but if you have them, hooray. So at least your facility will be there. So the best way would be for you to create partnership with the registered nurses, enrolled nurses, or all those who will offer those services. Even though they are offering their services on a contract basis, you do TOPs on Tuesdays and Fridays, they know that they come on Tuesday and Friday. So you'll be able to list them there. So this will be the last page then, and then they'll be they'll be able to come and do the assessment. I've got inside info on what they need when they come for assessment. Some of the information, in actual fact, all of it is what I told you in the beginning. So, but I'm not allowed to show you the assessment form because I might be arrested. I might be taking somebody's job. So the complications and failure with medical TOP, they are minor ones like diarrhea and hyperthermia and allergic reaction to misoprostol. The major one will be a uterine rupture. Please, when you have uncontrolled bleeding, always suspect uterine rupture. Rather have the guys there at Charlotte Makeko or at Bara be irritated at you as a GP for wrongly referral than have a patient die from uterine rupture because you were doubting yourself. There could be hemorrhage that needs a transition. There could be sepsis if you're not following these aseptic techniques or sterilization of your equipment. You might perforate if you end up doing a suction curettage because you might be over enthusiastic when you're doing your curating. If you perforate, there could be bowel and bladder injury. But do not forget the most important part, the emotional trauma, which is why you are going to counsel the patient first. And you also have post-abortion care, which includes counseling of the patient and to find out how they are doing. If you don't think your patient is coping, please do not shy to refer them to a psychologist or psychiatrist. So the other complications that could be there could be loss of reproductive function, either from because of sepsis, end up having a hyst, or Asherman syndrome from over enthusiastic curating or MVA, such that the uterus will now close. You might have failure, which is common in an ectopic pregnancy. Hence, you need to do an ultrasound all the time. Even if it's your girlfriend, do an ultrasound. If it's your neighbor, do an ultrasound. It does not matter. Always do an ultrasound. Do not do TOP, be it medical or surgical, before you do an ultrasound. So if in your practice you don't have an ultrasound facility, you can send the patient to the next GP who has a sonar to go do sonar. They still come back to you. So another reason for failure is because you have either used the wrong dose uh, or there's a concomitant use of other drugs that could be opposing, or the wrong technique that you are using. And in a nutshell, that is all. The cost of treating illegal TOP related complication is so high and it creates a burden to the public healthcare system. Please, let's try and make sure that we put an end to this illegal TOP. Furthermore, these illegal TOPs contribute to maternal mortality and morbidity. It is our duty as healthcare professionals of all ranks to provide safe abortions and contraceptive care to the patient in our society. Healthcare workers also contribute or influence or exacerbate these illegal TOPs. I don't have to go in and tell you how we exacerbate it, but the fact that you are running one without a registered practice, you are exacerbating it. So I want to encourage everybody to go train, register your facility. Even if now you don't have a facility, go train. A skill acquired cannot be unacquired. And you don't know how tomorrow prepares you for. train, register your facility, be safe from litigation and disciplinary action from the HPCSA. Thank you. So these are the resources that we have used in if you want more and more information related to what I was talking about. Thank you.
Thank you so much, Dr. Langalani. We appreciate it. It was a very, very comprehensive presentation, from the medical expert, from assessment to the procedure, to how we can actually make it legal and get ourselves registered. It was really quite a mouthful. We really appreciate that. I know you move very, very quick, and I'm sure you've already seen some of the questions in the Q&A. I don't know if you want to tackle them.
No, today I behaved. I didn't check the questions.
No, that's fine. I just got disconnected, but I was noting them.
Okay, the first question says, where can I get training?
Exactly.
Like I told you, the last slide has a website for IPAS. IPAS affords the training. Perhaps I must, okay, where is that email address? It was sent on WhatsApp. So there's an email address. A person who asked that question, please, Billy, I'm going to send you that email address so they can send an email so you can give them a feedback.
Awesome.
Thanks, Dr. Mbodi. What we can do, all the resources will be shared via a follow-up email with the attendees. Good. So I think that is fine. Sure. Maybe a question linked to that. It seems like I understand that there's one or two providers, but it seems like there is some challenges with people accessing training for this service, and that might actually fuel, the issue you keep on raising around the illegal services, because the idea is that if a woman comes in, requests a service, and we are not able to provide, she's likely to go anywhere, and end up with the severely illegal services, for a lack of a better term, And there are regions, I can tell you, where these services are not even available. I mean, the accredited services are not even available. I've had one or two calls from women in their regions. I ask around, you find that you can't get a properly accredited service, because as well, you've mentioned when you opened that a health worker who's not yet transformed, who's still not buying into the program. And we know that we have a lot of health workers who do not support or believe in the program. So that creates like a pool, it can actually push health workers to start to offer the service, even when they have not followed the required processes. But maybe you want to comment on access, overall access of the accredited service in the country. Sure.
So this is in two parts. That the facilities, it's true what you're saying. There are people who try to monopolize this because it's a business now. So they'll try and limit. But we are some of the people who are advocating for safe TOP for all our patients, all the women to have safe TOP. I will say for one, I've got, I had communications with the people in the province. Unfortunately, I'm talking about Gauteng, not other provinces, regarding this issue, and they acknowledge that there's a problem. And there's also a gap, because they say that you must have facilities so that they can come and evaluate. For you to have facilities, chances are you will start practicing. Then I told them about that. They say, yeah, as long as we know that your intention is that, you would have gone for training, which is not difficult. You are going to get an email, and I saw somebody says that they want that email. And then once you have that training, now you prepare your facility based on what I've given you as a facility that can do TOP. You prepare it for that to be that way. When you're preparing your facility to be that way, then you do an application, but you still continue with practicing what you can do. Remember, your HPCSA will say you shouldn't have done this because you are not trained. It will not say that your facility is not registered, because you would prove to them that I've applied, and the application has that gap, that it says that you must have the facility for it to be accredited. So I cannot have a facility and just sit. So if you are renting a building, you cannot say, no, don't worry, because these things might take a long. And we know in our country, unfortunately, the issue of chocho is a problem. People who want to be paid chocho delay to come because they want you to grease so that they can come and facilitate. So anybody who has a problem with trading, so we can facilitate that they get the training everywhere in the country. Everyone who has a problem with registration and accreditation of facility, and they are just meeting, hitting a block, and they are in Gauteng. That part, we know where to go in Gauteng. We can go there and talk for them. I'm not talking about accelerating. We are talking about making sure that that application is done. This is not about me having contacts. I can talk to my people who will come and do it. No, no, no. It's not that. It's purely going there to complain and say, guys, I came to you and say I'm going to give these talks because we want to improve a safe TOPs there in the communities. And you gave me your word that you will help by registering and pointing towards the correct direction regarding the training. And hence, 1, 2, 3, 4, 2 people are getting blocked here. So the people I'm talking about, we know them personal, so we can go there, not because they are MECs. No, they are people who are supposed to come and evaluate whatever that you have, whether so that you can meet that criteria. So I think we need to do it that way. As a follow up, I will go and raise it with one of the ladies who was there on the form. Her name is written, Daphne. I'll go and talk to Daphne about it, that this thing was raised in this portal, so that when with follow up and the subsequent resources that you send, people will know what steps to follow if there's a delay in the registration. But please register. If you are failing, please contact us. We know that it's business to you, but it's safe healthcare services to our patient, which can happen to be our daughters and our wives and our neighbors and stuff. So we want them to get proper and healthy and safe healthcare service. TOP service is a healthcare service. There's a question on an unconscious patient that the person might wake up and then now say, I didn't want that TOP, I'm going to sue. So I should have added that this is a patient with a medical condition, not a person who's coming to do TOP by choice. Remember that the act says choice on termination of pregnancy act. So this person who's unconscious cannot be choosing to do termination of pregnancy because they're already unconscious. You cannot choose. So this was applying to a patient with a medical condition that is likely to threaten their life, like severe preeclampsia and eclampsia. So because it would have been documented as to who got the consent, the consultant or the small senior on the floor, the hospital or facility CEO, and then the other person, according to the act, had also given the consent, there won't be any litigation in that application. This is not TOP by choice.
Okay. Yeah. There was a clinical question, Doc, around a patient, previous Caesar times 1, who has just fallen pregnant and she comes in for the services. The dosage, what are the risks and how do we approach such a scenario?
Thank you so much. For a previous Caesar is a risk for both surgical and medical TOP. But because today we're talking about medical, let's focus on the medical. One, we always have had this condition and say prerequisite is that uterus, that scar should be more than 24 months. So in other words, the last pregnancy should be 2 years and above. People have modified it to 18 months, but I'll say that to be on the safe side, you are going to do this medically on patients with a previous Caesar or previous myomectomy, which was done 24 months and above. So you can say at 18 to 24 if you want to have a net of a safety. And then the issue regarding the dose. So with mifepristone, you are still going to give the same dose exactly as it is. With misoprostol, the first dose that you are going to do, the better option for you will be to keep to the same dose. But remember that I said 6 hours, this is what we do. And then I showed you that the DOH says 12 to 1 to 2 days, which is 12 to 24 hours. I will say on these patients, rather do give the mifepristone now and stick to the 12 hours. That is as per guidelines. Because you will not have an add-on effect on the uterus if you use it that way.
So then what happens if she comes earlier? Are they supposed to be referred, or what's the protocol?
If you are doing it in a facility that meets that criteria, remember that the risk is that she will bleed because of a rupture. You can resuscitate the access to transport. You can call. So you can still do that as long as you note it, because the biggest mistake is we just give these tablets and say, go home, that's it. As long as you note it that previous Caesar times one, more than 24 months since the Caesar, and then 9 weeks pregnancy, requires TOP. And then you say you are giving mifepristone and you write there, take this one now, the other one to be taken tomorrow on this time. So you'll be safe. But then you tell the patients that should you bleed, should you feel that the pains are no longer tolerable, perhaps this is a sign that there could be a rupture. Please go and visit a hospital. If you are a facility that conducts this, you rather bring her back so that maybe she might be exaggerating. It's the normal process of the TOP. But the facility that we have, in case you are talking about those TOPs we'll do in the facility, you're supposed to have resuscitation equipment. So you'll be covered because you'll be able to resuscitate this patient until you refer them, because you have the transport or means or access to transport, means and access to the theater, means and access to referral to other hospitals. So you can still do them there. So
just a quick one. Before 24 weeks, is there any option, or what happens if she presents 6 months after delivery? Caesar times one, yeah?
So these are the patients that, irrespective of the gestational age, so rather take them and say we are going to do surgical TOP. So by surgical TOP mean that you can give one misoprostol, PV in the posterior fornix, just to ripen the cervix. Once the cervix is ripe, if it's an early, less than 12 weeks, you do the suction curettage or you do an evac in theater. The reason being that when you are doing those, it's a controlled evacuation. The evacuation in theater, again, you must be conscious, doing things, don't be over enthusiastic, but the most important part is to identify when you have perforated, which is simple. If you are doing a suction curettage or evac and you start seeing fat, the uterus has no fat, no matter how obese a woman should be. If you see fat, it means you have made a hole and now you are bringing fat from the omentum from inside and outside. If you start seeing chocolate, something brownish, you know that the product of conception should be red. So it's not, it means that you have perforated into the rectum, uterus into the rectum, and now you're bringing stools down there. So the whole point is if it's a fresh, so-called fresh scar, rather do surgical TOP, even though it's a less gestation, even though it's less than 9 weeks.
Yeah, that was empowering. Thanks, Doc. I know we spent a lot of time on it. Thanks. Yeah, sure.
So somebody asked about if you are going to give the patient to go with at home, what does the law say about this, and what if they don't reach the posterior fornix? So theoretically, every patient can reach the posterior fornix. So it's all about the position. I hope my hands are visible enough.
Yes.
Yeah, so if you are sitting and you are Billy, but you are a woman, you want to put this misoprostol in here into the vagina. If you overflex, what happens is the uterus and the cervix come to the fore. So you overflex and then you put deep down there, it will be falling in there. But if you don't want to go into that much, remember that we said the routes are the same. You can give oral, you can give buccal in between the buccal mucosa, or you can give vaginal. You don't have to stick to vaginal. And the law agrees the patients can take the treatment home. Like I said, misoprostol is not a drug registered for any other thing. It's registered for ulcer. All the patients with ulcer take it home. Mifeprostone, the patient would have taken it here. It's an abortifacient, but there's no law that says you cannot give the patient an abortifacient to start at home. Commonly, I've given patients in private who say, I want to start in the comfort of my house because I don't want to do this here. And because of previous experiences, I end up agreeing. There's a patient that I had seen before who was going to drive to Pretoria, turn on the way, and said, now I've started bleeding. It came out. And then I realized sometimes this can be fast. So as long as the patient understands it, you can see this is the patient who can take instructions, and it fits the criteria for it to be done outside the facility, then you can do it.
Great. I think you have addressed most. Is there any other?
Where in Limpopo? Somebody, I saw a question about in Limpopo. Where in Limpopo can one train? I do not know, but I'll go and look into. I'll ask these guys from Gauteng because they probably know the other provinces. I'll ask them to compile me a list for everybody else. But I think IPAS is an international agency, so it's all over the country. So if you go to the IPAS website and follow the email that I'm going to send, you'll be able to get more information on access to training. And then you'll go to the provincial health to now tell them that you have trained, you want to register your facility for TOP.
I think there was another one on the use of Prandin gel as an alternative to misoprostol. If that can be used, then what the dosage would be then?
Yeah, so Prandin gel has been used in most instances for induction of labor. The difference between the two is with the induction of labor, it just ripens the cervix. And then we know that when the pregnancy is big, with the cervix ripening, there's a pull that happens between the cervix, the endocervix, and the membranes. When that pull happens, it stimulates a lot of prostaglandins release. So it makes sense to use it for induction of labor. But for TOP, you are talking about the conceptus that is floating out there. You might ripen the cervix and nothing happens. So there's no evidence to use it for that part. You might have used it before and it works, but based on the fact that it's costly and there's no scientific evidence to prove it, I'll say do not use it, not as yet. Maybe unless there's a better formulation, cheaper formulation, and newer formulation. The current one, I do not recommend that you use it. Mabatwa says, what is considered a failed TOP? So I think he's asking this question because I had said there that there's no limit on how many you must do. However, everybody agrees that if after 24 hours of your attempt, the TOP has not happened, consider it failed. And then you need to go and look for other factors that could have contributed. So when I say 24 hours after, I mean 24 hours after you have done both of them. If you're using the DOH, a recommendation of saying mifeprostone now and 12 hours later, misoprostol. 24 hours after that, misoprostol. If it does not happen, consider it a failed TOP, and then you need to go and look for other causes which I listed there. So he says the question, do you repeat? So if you have given the misoprostol because it says that there's no obvious cutoff point as to when, except now that I'm telling you that after 24 hours from the misoprostol. So, but you are going to look and individualize your patients and say that, is it worth it giving this patient more and more diarrhea without her benefiting because misoprostol is not working? Should I just give her more and more hyperthermia and allergic reaction to misoprostol? So if you have to individualize your patients based on the period, what you want to achieve, and the side effects profile that is there. and then you'll upgrade or triage them to do a surgical TOP. And again, this is why you need those for you to set up your facility. Have a room for failure, and say that if it fails, then I'll be able to do an MVA because I have an equipment, even though it's 9 weeks and less.
Yeah. Thanks,
So
Doc.
the last question then was, what
Yeah.
if the patient decides to say, I don't want the TOP anymore? Part of your counseling should include telling the patients, I'm happy, Dr. Mabato, you asked this question because there are nurses who want to do this TOP. Part of the question counseling includes telling them about the side effects on the baby. So you know there's something called Mobius syndrome, Mobius, which mostly is about facial deformities of the baby after exposure to misoprostol. You need to tell the patient, you have done the counseling before. Once you start, you tell them that we need to continue because there's a likelihood that if we stop now and the pregnancy progresses, there might be a Mobius syndrome on the baby. And you wouldn't want the patient to sue you for giving birth to a Mobius syndrome baby. Although most of them do not survive longer, but what if this one survives? And even though she doesn't survive or he doesn't survive, then the patient sues you for an emotional trauma because of that deformity. So counsel them and tell them that once you take it, because there are side effects on the baby if the baby gets to live, although it's rare, they must know that this is what will happen.
Langanani, I noted one question on follow-up of after a medical TOP. What follow-up, or perhaps what should the patient expect? So they will bleed for how long? Must they come back for a scan? Should they do a pregnancy test? And at what point should they do so?
So depending on your practice, if you are doing a purely medical TOP, protocol says they don't have to. There's no role even routinely calling them back, unless you have told them that if you continue to bleed a lot, the way we define a lot, we say any bleed that is more than a menstrual bleed, any bleed that is more than what you bleed in a number of days when you menstruate, it should be a lot. If this patient tells you that I menstruate for 5 days, so you tell her if you bleed for more than 5 days, come. She tells you that I change 1 pad a day. You tell her if you start bleeding and you are now changing 3-4 pads a day, you need to come back. That's worrisome. So, and this is where you have an indication for doing sauna. But there's no reason for routine doing an ultrasound. I know that I, for one, am somebody who would rather go and do those ultrasound repeatedly. But there's no role. I'm looking into the financial component of the patient. Unless in your practice you offer a package for TOP, and your package is from the first day until the last day, I say, now you are done. You don't come back anymore. They pay once. You don't now charge them for other ultrasound. You can do that ultrasound for your own happiness or for your own safety. Of course, training does not expire. Once you train, it's for good. So I saw somebody says they've done training with so many people. Now take it further, go register your facility and go do TOP and do safe TOPs out there.
Just one quick one from myself to Talangan, and we see it as common practice where, you know, some colleagues would actually just give cytotext, say when you start bleeding, just report at your nearest facility, probably because of the challenge of getting authorization or accreditation for facilities. Is it what are the legal issues? Can one opt to just offer medical, and if that fails, you just go to the hospital? And therefore not need the theater facilities, not need the MVA staff and all the emergency issues, and just have the drugs? Is it legal? Is it illegal?
That's very unethical. So I know there's one colleague of ours who was called into the HPCSA regarding that. Please do not risk your practice. So suppose that you are now trained and you have your facility that is ready. If you are doing TOP for medical reasons, complete it there. Do not give the patient misoprostol and miso and say when you bleed, go to the hospital. Tell them that this is purely medical, does not need anything. If you think the patient needs surgical TOP, rather refer them. I know there's a temptation because of this limited in the services. even in the public sector. But always think beyond what will happen afterwards. Always practice safe medicine, because you wouldn't like to lose your license because of that 800 that you charged for those tablets that you've given. Rather err on the side of caution. If you like giving these services, please do the correct things. Go train. If you have trained already, go make sure that you have all these required facilities. The beauty of the gap that exists between your evaluation and having facility running is that once you have applied, you can now tell everybody that I've been waiting for 3 months for the application, but I'm paying the rent for the building, which you said you wanted it to be there in your application form. So, and I trained, I'm giving these, and these are the equipment as per prescription from the Act. I've got all the resources, and then you can carry on in your facility. Of course, if there's complications, do not shy away from referring patients. Never ever shy away, never, because you'll end up losing a patient unnecessarily because you're scared that body will start talking about you. Then do not risk your practice number because you are scared.
Yeah, there's a manager, our provincial manager says, Ansi, I'm not sure if I'm putting you on spot. Are you able to hear me? I wanted to allow you to just share what the procedure is in the province, or any other comments you might want to make.
Well, okay. Good evening, colleagues. Thank you, Dr. Mawela, for the opportunity. But
Yes,
I think the same system will apply even in Mpumalanga. When you need to open a private CTOP, you also apply. Yes, you can send to the HOD, but through the quality assurance, because that's where they're doing accreditation of private facilities. So, and then the process will start from there.
Okay.
Yeah.
And then, yes, you may also mention any other comments around the topic. I don't know how we are doing as a province. Septic abortions, are we having a reduction? Are we okay?
No, not really. Whatever what the doctor was presenting, it's actually what is happening in Mpumalanga. We still have a lot of our sisters that are still accessing the services from, I don't want to call them any other ways, but we always see them when they come, they're already septic, and some of them, they lose their life. So we are encouraging them to go to accredited facilities or go to the nearest public health facilities, get some information from there. If they don't provide, they will be able to refer you to the nearest facility where they refer their patients.
Yes.
We're trying our level best to increase the number of facilities. We are doing that. It's one of our priorities.
Dr. Mbodi, what's your key messaging to health professionals? I don't know what's the right word, who are not supporting the program. I mean, how do you go about encouraging health workers that this service sometimes determines, life and death and so on? But yeah, let me hear from you. Thanks.
So, thank you. Bearing in mind that South Africa is a free country, our constitution is very liberal. You've got the rights, and nobody must come and walk onto your rights, including the religion. And most people quote religious practices and say, "Me, I'm a Christian. I don't do TOP." But surprisingly, the same Christian will go and have sex outside marriage. But that's for another day. So, but what I want to say to you, please bear in mind that the Act also covers you and say, if for any reasons, traditional, personal, religious, or any other reason, you do not do TOP, when a patient comes to you, you are mandated, it's your duty to refer them to those people who do TOP. If you do not, please know that you are liable in the HPCSA. If that patient complicates and that patient complains, you are liable. You have to tell them that I don't do TOP. I know Magagula does. Please go there. Even if it's in the hospital setting, you are on call or you are in GOPD, somebody wants TOP. You don't just turn them around and say, I don't do TOP. That's it. Leave. You can tell them that today I'm doing GOPD, But the people who do TOP, who don't have a problem with TOP, they work here Monday, Thursday, and Friday. So do not come on these days. So come on those other days. But give them direction. It's your duty. You are responsible. You must give them direction so that they don't go back and do street abortions and come back septic and lose their reproductive life and they end up dying. Please know that it's a punishable offense by the HPCSA for blocking a patient from doing a TOP, irrespective of your religion, your belief, your tradition, or your personal preference.
Thank you. Thank you very much, Dr. Bodi. I think, I've taken a lot, I think, from your presentation, particularly around the quality elements, the importance of training, the issues around compliance with the law, why our facilities must remain, must be accredited, and we must maintain, whatever requirements that have been put in place. Dr. Magagula, would you like to say your closing remarks as we are about to close?
Just to appreciate Dr. Mbodi again for his time and all the participants. I think we've all acknowledged that TOP does save lives of women. I mean, the data is there, it's been presented. So let's all support women in their choice to opt for TOP.
Thank you. Thank you very much. Dr. Mbodi, thank you very much. It was a great one again. Dr. Magagula, really appreciate your time and effort as well. Colleagues, note that in 2 days' time, we are going to be discussing prostate cancer. Next week on the 7th, we are looking at patients who are failing ARVs, particularly dolutegravir. Our next seminar in obstetrics, we are looking at the impact of non-pregnancy related infections on maternal deaths. And we have Dr. David Mvula, who's a specialist ONG as well from Namibia. Just to remind you to visit our website, become members, support the platform so that we can continue to offer you these services and help you to maintain your professional competence, which is very important, if you are going to provide quality care. Thank you very much, everyone. Dr. Mbodi, Dr. Magagula, and the audiences. Ansi, thank you very much for your comments. Good evening.